if I'm doing a VATS. And this is very easy where I can just have them come in so I'm not going to have them sit in my OR for the whole case. They just need to be there for 10 minutes or 15 minutes to finish the anastomosis, and then they can leave. And they're also around in the same hospitals, so they can see my patients post-op regarding to bowel function, and in case we have any problems, to help manage those as well.
Okay, thank you, Abhishek. So there is a question from the audience. Is there any suppository medicine that can help with rectal pain?
So, I mean, suppositories for pain will act on pain receptors because they absorb through the rectal venous plexus, so they'll act in general for that kind of pain. There has been some use of duloxetine to help with the trapping of gas. In some cases, in the pain management clinic, that's what some of our pain management specialists use, along with nerve pain. So peripheral nerve pain is treated with pregabalin or Lyrica. And the central pain, they kind of use amitriptyline or gabapentin, and they use like a combination cocktail to help manage chronic pain in patients. But that's about it.
Okay, thank you, Abhishek. So Ben, may I ask you, there's another question. If you want to take this, what hormonal therapy would you recommend to a patient having both endometriosis and adenomyosis?
There's no specific one that, like I said, I would recommend. It depends really what is your, first of all, if you have any risk factors, for example, and you cannot, for example, take the combined oral contraceptive pill. But again, it's not that I would recommend the combined oral contraceptive pill instead of, for example, a Mirena coil. It really depends how you would like to take the hormonal contraception. If you want to take it as a form of a pill every day, you can go on the mini pill, you can go on the combined oral contraceptive pill. If there is something that you think, well, I might not remember every day to take the pill, I would much rather have like a Mirena coil. Again, the Mirena coil can work perfectly fine. Some people find a lot of benefits on the depot injection, so the progesterone injection, or the implant, so they can do it every 12 weeks or so on. There is no one specific one. Again, I think if you do have severe endometriosis, and for example, you had a treatment done with excision surgery, if you had a cyst that was removed from your ovaries, I do think that it's probably beneficial to go on some kind of suppression with some form of hormonal contraception. But again, I wouldn't personally push you towards one rather than another one, because it's more about compliance, because the different form of pills they have similar type of hormones, but the other molecules that they use to put them together, they're different. So one pill that might be very good for you, your friend or relative might find it really not that great. So it's very personal, this kind of choice.
Thank you, Ben. I completely agree. Abhishek, do you want to take another question?
Sure.
So, I wanted to ask you about the connection about tight pelvic floor and endometriosis. What are the symptoms of this situation, and how much pelvic floor physiotherapy could help? Do you have any experience?
Yeah, I work with a couple of physiotherapists. So I operate in Mumbai, but I also operate in Bangalore, and I have very good physiotherapists in both cities and physiotherapy plays a good role in preoperative preparation and also in postoperative recovery. So I would explain it simply to patients, like if you imagine that you have a cracked rib, you're constantly kind of changing your posture to protect that rib, and that change in posture and limitation of movement is itself going to lead to some dysfunction there. So similarly, the same kind of thing happens with the pelvis. If they're in constant pain and the pelvic floor is, in constant spasm, there is going to be some dysfunction in the long term because of that. And I think the physiotherapists will do a very good role evaluating exactly what that is, and they can do an examination, a digital examination, to ascertain where there are trigger points and treat those. And also, if there's any dysfunction and there's breathing exercises and stuff they help them with. Also, we have a lot of vaginismus and dyspareunia not necessarily just associated with the endometriosis, but that also needs physiotherapy to help, enable them to have intercourse. So I think the physiotherapists are a good adjuvant part of the team for the multidisciplinary care of endometriosis.
Yeah. Okay. Thank you very
Can I
much.
just add one more thing, Dino? Sorry,
Yes.
regarding
Yeah,
the
of
question
course.
before.
Of course. Yes.
I think there are also like a couple of treatments that you could potentially try in terms of non-surgical. Like there is Dynogest, for example, there was is a tablet that was designed for endometriosis, which some patients find a lot of benefits. And then recently, I don't know if in Greece or in India, you have also this one now. Has been recently approved here in UK, the Lugolix with northeastern. It's called Riequo. Do you guys?
Yes. Yeah.
Yeah, so now it's just been recently approved for endometriosis, which is just a fancy word to say like is a GnRH antagonist with that back HRT already. So it's a tablet that you can take every day, so it doesn't have to be an injection like, for example, the Zoladex. I don't have personally much experience with the Riequo. I haven't really prescribed it much. It's just been approved now here in UK. I don't know if anyone here from the panel has much experience about it, but this is now a new other alternative.
I want to add a point about the medical therapies, though. It's very important to do the thorough evaluation of the patient before advising medical therapies, because it's contraindicated if you have some kind of urethral infringement or even some kind of bowel nodule that is threatening subocclusion or occlusion. You have to have that workup in place. We've seen it, of course, which is being missed by general gynecologists most of the time, and patients can end up losing kidneys because they're on prolonged asymptomatic therapies because of the medication.
Thank you, Abby. So we're moving to the next session. We are on time. So I give the floor to Kathleen King. So Kathleen is well known for her work in endometriosis. She has dedicated and sacrificed much of her free time raising awareness. And I think that people like Kathleen and Wendy really make a difference in all of that, because if there weren't people like them, as doctors, we wouldn't be pushed to learn more and be better and help patients. We would continue to excise cysts, give contraceptive pills, do ablation, and everything is fine. So I believe their work really makes a difference. And I give the floor to Kathleen. So Kathleen, welcome. And
thank you so much. And as you say, like without the patients, that there's very little sort of services there. And I think in March, the Awareness Month brings a lot of focus on the patient side. And now we're starting to see a huge amount of focus on the medical and surgical side. And that is fantastic to see. And I'm delighted to be joined by 3 other advocates here today. And I think the education that we can bring, the nuance that we can bring to the discussion is always very important. So Bojana, I'm going to speak with you first in terms of your journey. And I think you represent so many people worldwide who've had to up and leave their own home country to get treatment, to get that adequate treatment. So can you tell us a wee bit about your journey and maybe some of the challenges that you faced in getting a diagnosis and treatment?
Yes, hello. So my road was really through the fire and the flames. I started getting my first symptoms in 2018, since I gave birth to my little one. I started getting random migraines, fatigue, tachycardia, dysmenorrhea. My periods were hellish. My immunity was so low. So the symptoms were becoming more intensive from year to year. I was regular at the doctor's in my town's hospital, Shabbat. So I went to public hospital, as you should. No one could figure out what was wrong with me. They started questioning thyroid gland, no. Kidneys, no. You are healthy. It should hurt a bit. Periods are supposed to hurt. I had huge pain. I lived in constant pain. in constant pain for last 6 years. So I went to the ER after I had a normal day, 19th June, riding my motorbike, went home, and in my underwear, I saw a literal bowl of bloody meat. I went to the doctors in public hospital. They were like, your period got early. That's all they said about it. So that was a breakthrough moment. I went privately to Dr. Vladimir Ivetic from Shabac. He did a regular exam, and he did external and internal ultrasound exam, and that's when he sat me down. He sat me down and told me, I'm sorry, but you have a severe case of endometriosis, and it's incurable. Still in Serbia, there's a common myth that there's no solution for endometriosis. But I have my best friend who went to a surgery to go to Dr. Dinos in
so it doesn't matter. It doesn't matter to whom someone goes.
She did a surgery, and she was like,
what
no,
matters,
we're not touching you here, because
yes,
one doctor wanted to give me hysterectomy, and I'm only 27 years old now. He wanted to give me hysterectomy. Yeah, that's the cure, apparently, here. And I got in touch with the doctor, and I had my surgery in November. And only 4 months after the surgery, I'm living my life pain-free, completely painless. I am living my life normally.
That is amazing. That is so good to hear, because you've gone from a situation where you were dismissed and not being believed to being given something that definitely is not a treatment or a cure, to finding somebody to advocate and to operate and to get your quality of life back. That is fantastic. And in terms of learning through somebody else, do you find that the shared patient experience is really important in not just educating yourself, but also reaching out to other people to let them know what is out there and to let them know to ask those questions?
Exactly. The experience from other patients are really important, because many people are misinformed. And yeah, I forgot to tell you one thing. After 6 years of searching for what was wrong with me, I started doubting my sanity. And one doctor from the public hospital in my town sent me to psychiatrist.
It's shocking. I still see that on a daily occurrence here in Ireland as well. We don't believe women. We don't believe young women in particular. We're not treated as reliable witnesses. I'm sorry you've had to go through that. And really, in 2025, nobody should be facing into this. I think, again, as patients, we have a really strong sort of responsibility in one sense, not just to look after our own health, but to try and look after those who are coming behind us as well. And I was taught 20 odd years back that if we can reach one person, it makes a huge difference. And Bojana, I know you speak out quite a lot about your case as well and about your journey, and I think that's really important, and thank you for that. I'm going to lead in now to Wendy. Wendy, I've known you, I think, as nearly as long as I've known the whole endometriosis community. Wendy, you've done great advocacy work as well. And leading on from Bojana there, where advocacy is really important, but what inspires you to take it from just an educational and a treatment point of view with your patients into advocating, especially for extrapelvic? Oh, Wendy, you're on mute.
I do have to mute myself.
Right.
Coming from somebody who experienced endometriosis that fell outside the little box that everybody's been put in for so many years, that you would hear in the media, they would give these stories, but it always ended at reproductive disease. It ended on fertility. And absolutely, this needs to be talked about. This is so important from a reproductive standpoint, that it continues. And we know that women have been, put into that little box, and we're here just to propagate children. And there's so much more to life beyond that. But it was very frustrating because everywhere I went, nobody was looking at endometriosis, and it came upon myself through Nancy's Nook that I was talking in there, and I'm like, wow, they say this is really rare, and it just cannot be. And so that's what made me go down that rabbit hole and start to look at all the holes in medicine and how everybody is in their own little silos now. We've become so specialized with so much information in each little silo that doctors, I think, are really missing the big picture. And it comes down to that general practitioner who has to now juggle everything. And so you know that first point is that general practitioner. And from there, going on to different consultants. So that really drove me into looking at how come we're not getting diagnosed? What are the drawbacks? First, we knew the definition was an issue. The definition was, of course, very concise and incomplete. And it's still being hashed out today on exactly what the process of the disease is, whether it's a progressive disease or it isn't. So I got into the extrapelvic because there were a lot of stories that everybody said was the rare, which I actually feel like are more the mainstream, that has just not been recognized. And it's everything from musculoskeletal disease to nerve disease to, abdominal wall to gastroenterology to, the liver. Now we're looking at the liver, right? We're looking at the sciatic. I mean, you're seeing these things that have just fallen through the gaps. And I think it's because we as a medical society have learned how to, you do your first 10-minute scan, no matter what professional you are, whether you're a practitioner or your provider, you do your system scan. But I think sometimes it's so cursory, and to be honest, a lot of times it's now on a piece of paper and you're just checking the box. And unless they check something, the provider sitting in front of you is not going to go extend and interview that person. And also some of the symptoms they present with may not align with the typical endometriosis symptoms. And asking that simple question, is it related to your menstrual cycles? Are you noticing that association? So that's where I came in. I just felt like there wasn't a platform to be heard, that the disease is far bigger than what it's been siloed into, and that there's a lot of symptom profile that we're missing, and a lot of presentations that don't show up on imaging. So it's pressing imaging now to go back and learn how to read it, maybe improve the sensitivity of the machines to detect things. So yes, and knowing that medications are not a cure for the disease. So that's how I got here.
And in terms, Wendy, then of advocacy around that, how do we get that voice into the mainstream? Certainly when I started this journey, so long ago, I was told that if I would never meet somebody with stage 4, I would never meet somebody with thoracic. This is now a weekly occurrence. It's not rare. So how do we turn this advocacy into something that's really educational as well?
That is what I have been facing since I started this. Oh my gosh, how do I keep my thoughts on one track here answering this question? There's a lot of pushback. First off is when it comes to education, we know that the curriculum are set up by the medical system. So the universities, whoever's doing the training, and that there's a society in general, right? So you have your different, like the American Medical Association, and they oversee what the doctors and the universities are getting for credentialing. The people that are running that are the people who've been doing it a long time, and they don't know what they don't know, to be honest. And it's very difficult. I became a nonprofit solely, not for the sake of making any money, because I do this for free, solely so that I am a reputable legal entity to get into universities, to get into hospitals, to say, I would like to present this topic to you, to give your doctors continuing education if they will sit here and listen for an hour. But there are so many barriers to getting there. And I think unless you are teaming up with this panel of doctors in front of us and all the other doctors who have medical degrees and will say, hey, I'm working with this nonprofit, this community of advocates who are very intelligent, they're well versed in this disease, and they want to work jointly. I think that's the only way we can really go forward. Because again, you mentioned before, the patient's voice has been disrespected. It has no weight. And even though we're educated, and some of us have been in the field of medicine, and we understand how a doctor thinks, we're there. but we're still discredited, or we're put in that box as a patient, but not put in that box as both. So yeah, the barriers, I'm still working on those. Except I think it comes to teaming up.
Absolutely. It is tricky, and collaboration is so important. And I think, again, recognizing that there's expertise on both sides is absolutely key. We can be patients and we can be not just advocates, but we can also be, you know, sort of professional experts as well. I think using all the skills, all the tools that are out there is really important. We could talk on this all day, all of this panel, like, you know, but I'm conscious of the time and I'm going to keep this on time as best I can. Vicky, tell me, I just mentioned it to Wendy there a little bit around, you know, symptoms not being the norm and not being sort of ticking those boxes. I think you've got quite a disconnect between the textbook symptoms and your own. Could you tell me a little bit about your journey? Vicky, do I have you there?
Oh,
Hold on.
maybe.
Vicky, can you hear me okay? Maybe not. Camelia, can you hear me okay?
We can hear you.
You can hear me. Becky can't.
Yeah.
Hold on.
Hello.
Yeah,
Becky, we have you now.
yes.
Yeah. Okay. Hi. Hello, everyone. Hope you're having a beautiful day. My story. Okay, that's another. Yeah, you're laughing. Okay, good. A lot of ER admissions, many public hospitals, telling me since I remember myself, like late 20s, that yes, you're in pain, but you're totally fine. We don't understand why you are in pain, so we are setting you free. You can go home. Eventually, we will figure it out. That was usually the phrase that they were using while I was signing my documents to be hospital free after spending a night or two on the ER. Too many visits and private doctors also, trying to figure it out myself because the pain was unbearable. Like, I was literally fainting. Like during my period, sometimes I even remember myself knocking on my neighbor door because I have my toddler and saying, I'm about to faint, take care of the kid, and immediately fainted. So still, when I was going to the doctors, the answer was, your exams are perfectly fine. You look amazing. Your body looks pretty healthy. Yeah, but cannot be, because that pain has to be explained. Long story short, from different hospitals, I even got treated for, I hope I pronounced it correctly, is ulcer. For my stomach, like they said, oh, your stomach is dying, like you're literally bleeding inside. No, it wasn't. Okay, and then I got another treatment after 4 months from that, and I got a diet advice, like eat only, let's say, solid food, whatever, to help your stomach not be in pain. And after 3 months, my bowel was killing me. So I went to another hospital about this. So they said, oh, okay, now you have Crohn's disease. And they gave me a different opposite diet. And it was funny. And I'm like, okay, you need to know that 4 months ago, they asked me to eat exactly the opposite food from what you're asking me now. And then I got this funny look from the surgeon. Admissions, hospitals, ER, even less than 6 months from my excision. I went in and out in 2 of the biggest hospitals. One sent me to another. Both sent me like pretty healthy. So at the second one, because I went like noon, imagine the face on the look on my face that the minute I entered the door of the hospital, they left everybody that was, all around, sick people, and they said, this lady needs treatment. Like that was my look. So even though everybody followed on me, after getting my exams, and of course my exams were all amazing, I was healthy. They said, we see nothing. I'm like, seriously. Then they sent me to a gynecology hospital, saying maybe it's something like because of your period finishing like last week or whatever. Like it can't be like I was over like a week ago. So they sent me there like it was 3 o'clock at night after like a couple of hours there. And of course they treated me there. And at the end of the day, almost early morning hours, like 5, 6 o'clock in the morning, they signed me saying, everything looks amazing in your body. You're pretty healthy. So in desperate, I replied like, do you see me besides the exams? Do you see a person that's healthy? They said, no, but your exams are good. So you're healthy. Whatever it is, it will show up eventually. I'm like, seriously, like, come on, this isn't a joke. Like I'm suffering for years, and now it's becoming no description about it. You guys have been through this, and you know what I'm talking about. Stage 4, of course. How I got to know about this is I have a friend who's a general surgeon, kind of my age, and I called him. We were in school together, so I called him desperately, crying on the phone, saying, I don't know what you're going to do. I don't know how you're going to do it. We have to figure out what's wrong with me. So he said, I don't know what you have, but let's start deleting stuff. Let's start off saying, no, it's not this, it's not this, it's not this, and eventually end up to what it is. During those exams, I had my colonoscopy, gastroscopy, everything was clean and clear, perfect, okay? My bowel was removed, a quotation, by the way. Is that I kept on calling him after every exam that I got, and everything was supposed to be good, and said, Vicky, that doesn't make any sense. I have an idea but I don't want to say anything. I'm like, what is this? And then he mentioned the word endometriosis. I didn't know about it at all until that point. And nobody ever mentioned anything. And I've been in more than 12 private gynecologist surgeons, the best names, okay? Big guys, like amazing people, amazing doctors are supposed to be. I'm like, okay, what is this? He said, you know what, but who is going to treat you for this? Like, I don't know how someone to kind of know that he knows about it, really. So he said, I know a guy. He sent me to a gynecologist. He kind of knew about endometriosis, but he couldn't really control my endometriosis. He said, let's do surgery, let's not do surgery, and eventually said, I'm not touching you, which maybe was the best gift he ever did to me. He suggested me, before the good part of my story is that he suggested me to an oncologist. So when I visited the guy, he literally told me that I think I can save your life. That was literally what he said, and it was during COVID also. I can save your life, but you're going to have the stoma, the bag, and it won't really affect your life. I'm like, what are you talking about? Okay. And he was like, oh, this, I think we're going to do this. And like, he was so disappointed about my condition that I eventually asked, do you think I will make it out of the surgery room? That's my issue. I have a family. I have 2 kids. I need to be home. That's everything else I will solve. He's like, I think so. And then I collapsed. Why? Because I had to go home and think of how am I going to communicate this to my husband. Of course, not to my kids, ever, never. It took me more than 2 days to be able to find the words to talk to my husband about this. From that moment, I was almost crying every day, desperately saying, this cannot be my life from now on, or the end, okay? Because he gave me no choice. I need to find someone. And thank God I found my surgeon. God bless him wherever he is. He knew exactly what I had. The minute he saw me, he accepted to see me very fast when I explained my condition on the phone. He saw me very fast, and immediately everything became clear. Like, this is it there, this is there. I did some scans. We all know that the scans now are, okay, at some level you can see the extension of your condition. Some you cannot. He didn't make everything, rainbows and flowers, but I could, for the first time, understand what is wrong with my body. Everything had an explanation, okay? And when you have the information, it's easier to understand put yourself in a how can I say, in a safe mode. That was for me, and preparing my future. You know, I'm going to need this, and my questions were answered to the point that he could answer, which is more than respected for me. Like, what you can answer me. Don't give me anything just to avoid my questions. The time for my surgery came. Okay, it was stage 4. Ovaries, bowel, bladder, vagina, had it all, like a beautiful package. Thankfully, with his cooperation with the general surgeon, even my bowel excision, the removal of the actually totally destroyed part of my bowel, was done laparoscopically. So I didn't really suffer afterwards when it comes to the time that I needed to be pain-free. From everything else, I was pain-free the moment I opened my eyes. Honestly, in my heart, okay? My bowel only took some time. When I say some time, like 4 to 5 months to be 100% pain-free, because I was pain-free, and the minute I was stressed, immediately it was hurting, and I knew it was because of my mental stress and everything, and I was trying to keep it low. When I realized, and I was treating it, saying, okay, I know you heard it. I know everybody neglected you for so long. Come here now. Now we treated you. You can relax. You know, I was talking to myself. Now I'm exactly 3 years post estrogen. I'm living amazing, pain-free life. I had my periods afterwards without even feeling the minimum of pain. I was this lucky. Not even needed to take the simplest of the painkillers. Short, normally not 15 and 20 days of period and dying and exhausted and whatever. Normal periods, 5 days, 4, 5 days, whatever. Easy, in and out, done, living my life as a free lady. And now I'm trying as much as possible to kind of educate whoever knows my condition and ask me all those questions, because people also, women are actually afraid. I don't know if you're facing it also, that they are afraid to ask. They always text me saying, please, can I ask you something? Which is, you can feel the fear that was created 90% from the doctors and the family environment, telling them, no, you cannot be in such pain. No, you're not in pain, when they are actually dying from pain and they are suffering. So, and then they start moment by moment adding one more question to what they need to know. And of course, you can only answer according to your experience, okay? I can only answer my experience. It's important. It's important that, first of all, when you say you're in pain, you have to have someone looking in your eyes and not doubting that. What is the amount of people that will say and be, white ghost face pain, and actually faking it? Like, okay, what, 0.1%? Get pain right here.
That's so important. You've brought up a really, really good point, and I'm going to wrap up with this because we are short on time. But I think we're speaking to a very good panel of surgeons and doctors here, which is fantastic. But we need to reach the people who are not on this webinar and the people who do need to listen. And the most important diagnostic tool, as somebody who works in diagnostics, I work on the lab side, most important diagnostic tool are your 2 ears. Listening to the patient's history, observing the patient. Is the patient as white? Are they coming in with severe pain? Start listening to patients again. History is such an important part of that. MRI, bloods, all of your diagnostics are important, but it all feeds back to how that patient is experiencing their life and what's actually going on with them. And Vicky, yours is a great example of that as well too. So Bojana, Vicky, Wendy, thank you all so much. I'm going to hand back to Dinos now for the last part of this panel and just keep this on time. So thank you everybody for joining.
Thank you, Kathleen. I think your session was much more impressive than any other medical session I have seen. It's not pointless seeing videos of nice operations, etc. If we don't know what we are searching for, and if we doubt the patient, we shouldn't doubt patients. Pain is never in our mind. Women are not crazy. And you know the word hysteric. Do you know where it comes from? Hysteric. I recently read it in an article. You know, so of course you know that. Okay, so hysteric comes from hystera. Yes, it's uterus in ancient Greek. So women with endometriosis in ancient years, they screamed from pain, and people said, "Oh, there's the hysteric, the one that has a uterus." So the origin of all the myths surrounding endometriosis is are very deep in our society. So we have to change how we see, first of all, women. Okay, women are not here to deliver children only and work at home. They have rights, and of course, they are entitled to a pain-free life. So I cannot imagine what would happen if I had pain during my period, or if I had another male issue. I think science would have given the solution very fast if there was a male condition with such pain. But my question is, why do we have to go all this through? For example, delay up to 7-8 years to diagnose endometriosis. So well done to all of you for pushing the boundaries. Okay, so I will ask some questions from the audience. We have quite few. So Mikey, do you want to take the first one? So there is a lady that asks that symptoms have escalated after hysterectomy for adenomyosis, and also endometriosis was found during surgery. I suppose it was not treated. It doesn't mention anything about excision. So would you expect symptoms to increase after hysterectomy, but without dealing with endometriosis?
It's a really difficult question, honestly, because it really depends on the preoperative symptoms. Like, was there an element of adenomyosis? Was there not? What was the hysterectomy done for in the first place? How much endometriosis did we have? Is there any issues with back? Is there any history of essentially what are the symptoms really after the hysterectomy, right? Because we need to start thinking, okay, is it positional to start with? Okay, was the hyperextensions of the legs? Is the history of a disc prolapse? Is she having a sciatica now? Or other symptoms of pudendal nerve, for example? So it really depends on the symptoms that we're having after the surgery. In terms of endometriosis symptoms, honestly, I don't think so. I wouldn't, as long as the endometriosis wasn't excised or moved, I wouldn't really expect the endo symptoms to get worse. So the question is really, is it a new onset of pain? What's the pain pathology? What's the distribution of the pain? What nerves are sort of involved in the distribution of the pain? And it takes a bit of thinking in order to actually arrive at with an answer.
Thank you, Mikey. So since you have mentioned neuropelviology, I will ask Abhishek. Abhishek, we have another question from the audience. Is there any particular type of imaging more accurate in detecting endometriosis of the sciatic nerves? What do you use in your daily practice?
Yeah, okay. So like Kathleen said, the most important thing is to use what's between your ears and well, your ears and what's between your ears, and listen to the patient. She will usually tell you the symptoms, and that will help you make the diagnosis first of all, which is for sciatic, it'll be pain radiating down the lower back, down the butt, down the hamstring, down the leg. And now it's for the specialist to ascertain whether there is a nodule on the sciatic nerve itself, or if it's coming from the root nerves that supply the sciatic nerve, which is in the sacral plexus, if there's a nodule in the parametrium, which is usually in continuation with a rectal nodule that's extending laterally. So the imaging of choice over here would be an MRI. I don't think ultrasound is sensitive enough to pick up lesions that far out lateral. Even in the parametrium, you don't really have very good standardized markers, so it's going to be very operator dependent. Even interpreting the MRI is very operator dependent, but the MRI images are, they're reproducible. So I can see an MRI of a patient sitting 10,000 kilometers away versus where if I'm doing an ultrasound, she has to be present in my outpatient clinic to be able to do that. So for me, the MRI is much more useful for picking up disease on the nerve itself or in the parametrium, and that would be the gold standard. If you can do a protocol where you can put gel into the vagina and kind of prepare the bowel, that will make it a little easier to identify how much extension you have into the parametrium and into the paravaginal spaces as well.
Thank you, Abhishek. And the last question before we proceed to the next session is for Ben. A viewer here asks, can endo cause very specific pain and stiffness in the sacral joint? In this instance, should other conditions, for example, autoinflammatory arthritis, be ruled out to check rather than just assuming it's endo?
Can you repeat which joints again?
So a lady here asks if probably about sacral joint stiffness and pain. Could it be because of endometriosis, or should other etiologies like autoinflammatory arthritis be ruled out first?
I think again we need to go back to listening to the patient, to the overall symptoms, because if we are talking about isolated lower back pain with sacral area pain, and there are no any other symptoms related or similar to the classical symptoms of endometriosis. Again, there are so many conditions like Mike Adamczyk has already mentioned like a few minutes ago that could be responsible for pain. Unfortunately, like pain in the pelvis, pain in the lower back is not just caused by endometriosis. Endometriosis is unfortunately one of the most common conditions in women which causes pain and is one of the also like sometimes easier to diagnose. This is why we look for it. But once again, we do need to remind ourselves that there are many other potential causes for similar problems. Then, like, I think if a patient have lower back pain and it is also associated with other symptoms like painful periods, painful intercourse, problems passing stool. So if there are also other associated symptoms, then the more symptoms you have, the higher becomes your suspicious then of having also endometriosis, and then is where you're going to look more. But isolated symptoms is much more difficult than to diagnose.
Should I jump in, Ben?
Yeah, go for it.
Right. So you essentially what we need to do is actually what Caitlin said earlier: listen to the patient and find out exactly where the problem is, what's happening, what makes it worse, what makes it better. The way I always think about it is, if you think about the pelvis, it's a bony structure with quite a lot of nerves actually on the bottom of it and quite a lot of muscles on the bottom of it. Any tiltation of the pelvis, whether your one leg could be longer than the other one, whether you've got tilted pelvis itself because of muscular stretching or compression, can give you some type of pain. So for example, a good example of that is isolated pudendal pain at times, okay? One of the things that I personally always check for pudendal pain when I see my patients is, of course, I'll do my usual examination, straight leg rise, make sure that sensation is absolutely normal, but also measure the length of the legs, because one of the simplest way to, and I've seen that more and more, to treat actually isolated pudendal would be from, for example, one leg being longer than the other one. And essentially it's the way that the patient walks creates tension on the nerve. So I think we have to be really we need to essentially know the anatomy quite well, but we also need to listen to the symptoms. And yes, endometriosis is very, very common nowadays. We know that it's been common for a very long time. But sometimes we need to have a look at the whole picture. Wendy, you've got your hands up.
Thank you. I agree what you're saying, as well as writing on the tailcoats of piggybacking everybody. As a physical therapist, These are things, so when you're talking about sacroiliac joint pain, and these are things that we screen from the functional as well as the anatomical. So when you're speaking leg lengths, it could be a functional versus a true leg length. Was it the chicken or the egg of why they're walking like that? Could the pain have really caused them to deviate? And now they've got sciatica because of more of a functional thing. The musculoskeletal system's adapted and it's pain from that versus the endo. So listening to the history, are they compensating and developing sciatic pain because they have endo pain? And they're walking unusually now to try to circumvent that pain to lower the threshold of that pain, or is it that there's true endometriosis affecting it or near it? So I think from a PT standpoint, and I'm not a pelvic floor therapist, but I am a very good generalist. I'm more of a neurotherapist. So I think that the PT role really cannot be underestimated, especially if you're a physician. You have someone with endometriosis and they're having some back pain and they're having some other things that don't always fit that profile that you're seeing, to consult with them and have them do a screening. And it's not just the pelvic PT, there's also like orthopedic PTs, because we're trying to get the two to come together, because a lot of times one works at one part of the sacrum and the other one works with the internal structure. So putting it all together from the whole spine, everything, the legs, the shoulders, having a really good look, I think is really important. So telling our listeners as well as here about the team, use your PC, because they can at least help confirm what you're thinking, or they may see comorbidities there, whether they came before or after, but they're there. So yeah, excellent.
100%.
Okay, so let's proceed to the next session. I think Kathleen was the best moderator. She was on time. I'm running out of time, so I'm not a good moderator. Sorry, Kathleen. Bowel endometriosis. So bowel endometriosis is something very common amongst the endometriosis patients. It's something that worries many patients. What will happen if I have endometriosis on the bowel? Will I need the colostomy bag, or how do we treat that? Is the recovery easier? So Mr. Georgopoulos, the colorectal surgeon, he will discuss that for us. So Dr. Georgopoulos, do you want to share with us your opinion about endometriosis?
Okay, thanks, Dr. Kyriakopoulos, for involving me in that very, very nice webinar. And I'm going to start when I was a young surgeon on 1995. I remember a case where a young lady with ileum, as an emergency case, where I operated her with a stricture on the rectosigmoid that without histopathological result, we made a colectomy and a stoma. After the pathologist results, it could not reveal what kind was that. But now, knowing, working with you, what is endometriosis, I remember that for sure it was endometriosis. So, bowel endometriosis is a complex condition for women in the age years usually, which may lead to chronic pain, gastrointestinal symptoms, and infertility. The diagnostic methods presented by Ben and others also using transvaginal ultrasound and magnetic resonance imaging, where someone can detect nodules from the bowel. Usually there are 3 surgical techniques to treat the bowel endometriosis. the saving excision, disc excision, and rectosigmoid resections. We know that there is a big discussion about the choice of the kind of the technique, because it's completely different about the morbidity after these techniques. The gynecologist discussing with the colorectal or gastrointestinal surgeon decide what is the best. It depends from the how huge is the node, the endometrioma, the length, what is the circumferential of that node. We don't know the infiltration. If we have information from the diagnostic methods, it's okay. But usually, even if the diagnostic methods don't reveal that is infiltrating the bowel wall, we can see different results during the laparoscopy. Saving excision is like to peel an onion using different scissors, ultracision, argon plasma, or even monopolar hook. I know dinos don't like that hook, but I have read that some gynecologists or surgeons use that hook. It is very important, don't open the bowel wall. If there is a hole, even that we can put some stitches, avoid any leak. The disc excision is completely different, using laparoscopic cassettes or a circular stapler. So to put inside the endometrioma and take out that lesion. But it is very important to know that we don't remove the more than 50% of the lumen, because if it is more than 50% of the lumen, stenosis will be present. The most often lesions are to rectosigmoid rectum areas, but also can present to other lesions in the gastrointestinal tract. The most often of the others are the cecum, appendix. I know that the appendix, if it is very invaded by endometrioma, also we can see an appendiceal intussusception. So sometimes need to have also resection from that, but it is not common. We know that there is a big fear of the patient about the colostomy. If everything is very properly, we can avoid the colostomies or another ileostomy, for example, because it's different, the nature of the disease. It is not a cancer. We have healthy tissues. I mean, it is not a cancer invading the wall. and having not so good sanitary. So the patient could have a small resection, sparing the nerves, resecting very close to the bowel wall, doing anastomosis safe without problems. We know that sometimes there are problems with rectovaginal fistulas, but if also the vaginal is intact, it is not so usual to have fistulas. What other? For today, I was looking the bibliography because the last 5 years I'm involved in that disease. So it was amazing for me reading that there is a cancer risk. A cancer risk where the neoplasm linked with endometriosis it is up 1%. This is located outside of the ovaries, and around 50% of these cases involve an adenocarcinoma of the rectosigmoid colon. It is very important for me as a surgeon because excisional treatment of endometriosis can prevent also for another cancer. It is that strategy. It is very, very important for me.
Thank you.
That's it for me. And
Yeah.
okay, I know that it's a benign disease, so we should decide not to harm the patient, as the Hippocrates oath says.
Yeah, you're quite right. Thank you for your input. So thank you for unraveling this topic about endometriosis. So now we're going to Nikos. Mr. Bratis, he's a urologist. He's a laparoscopic and robotic surgeon. He's doing complex urologic cases. So Nikos, please tell us your insight about urinary endometriosis. And of course, how endometriosis can affect the kidney. So this is a major problem. It's a pity to, in 2025, to hear about cases about patients that have lost their kidneys. I don't know if endometriosis can be as bad as cancer regarding kidney loss. So I think, in my opinion, we should be more cautious and take any precaution measure we can in order to avoid such cases. So Nikos, the floor is all yours.
All right. So I have prepared a few things to discuss about the urological aspect of the endometriosis, but I've given so much stimulation from the previous speakers that I want to highlight a few things. Wendy said, I think Wendy was that we need to, our main diagnostic tool is our ears. I know the effort of the awareness for endometriosis that's going on, and I've been a recent member of the team I was recruited by Dr. Kyriakopoulos about 4 or 5 years ago. Until then, I had no clue at all. I knew the term of endometriosis, but I didn't know anything about that in the real world, the real clinical practice. So during my involvement, I realized that people are talking. The awareness is not for women to start talking about the problems. They were always talking about their problems. The thing is, and the problem is, who is listening? And I think that the effort should take the way towards informing the active medical personnel that deals with those patients. It's very, very rare for a woman to come first to a urologist. It's more often, but again, not that often, to go to the general surgeon. They go to the gynecologist, they go to the gastroenterologist. And all know, I'm sure about that now, that there are gynecologists that they don't have a clue about endometriosis. And there are gastroenterologists that they say, even today, that endometriosis doesn't affect the bowel. Whereas all of the previous speakers and Dr. Georgopoulos have been removing bowel parts for so long. I will not mention Kostas, who is after me, the next speaker. They think it's something out of the universe that it can affect the diaphragm or the thoracic cavity. Okay, so our goal should be to get the teaching society to get the endometriosis the entity that it deserves, for doctors now to be aware that this condition exists and it can cause huge problems. And this will lead me to what can cause from the urological aspect. First of all, it is a rare, in quotes, condition for the urinary tract. It affects 1% of the total endometriotic patients, but it affects about 50%, 20 to 50, the literature says, but we have seen it, about 50% of the patients with deep endometriosis. In a different extent each time, but it does affect. Even I think Dr. Adamczyk said, from the aspect that we need to peel the ureter out of a lump, and in that case, we can find that it's so stuck that we need to resect and do a ureteric reimplantation. Thankfully, rarely, but it does affect the urinary tract. We have seen, and last year we did 2 radical nephroureterectomies with Dr. Kyriakopoulos for kidneys that were like a hydronephrotic sac, not functioning at all, because of silent hydronephrosis, silent obstruction that no one attended, no one could diagnose it, and that resulted in the kidney to be lost. It has been mentioned before that there are women that they are undertaking medical treatment and different options and experiments or whatever, try to manage their symptoms, and in the meanwhile the kidney is lost because no one bothered to ask, if they cannot do it on themselves, to ask for a radiologist to do ultrasound scan of the kidneys to see the hydronephrosis. So it is a condition that exists. It's not a ghost condition. It is something that causes multiple problems. The prevalence is there. There are data now over the last years that they indicate that it can affect the bladder, it can affect the ureter, it can affect the kidney itself. We have an obligation to try to communicate that. My opinion is that we need to change our route where to focus our communication now, because women are talking. Vicky and Boyana, if I pronounce that correctly, they said they were going, they saw 10 doctor seats or whatever. They were dealt like a psychopath. They were given medication for depression or for anxiety or whatever. They were talking, they were communicating the problem, but the problem still stayed there. I know I took my my, let's go, speech out of the very tight medical aspect, but every time that I come to one webinar or any other action that Dr. Kyriakopoulos is arranging, I feel furious that I hear stories of patients that they have been suffering for so long. They were going to experts, and still they were dealt like psychopaths. So yeah, I will not go in depth. My main goal is to pass the whole message that if you have lower urinary tract symptoms, or if you think out of this communication that you have endometriosis somehow, try to find someone that can deal with you. And I always ask from my aspect for, if no one suggests, for a urological urinary tract ultrasound that might save one of your vital organs that's called kidney.
Thank you, Nikos. Quite enlightening what you said. Okay, you spoke like a gynecologist. You see, I don't know, your insights about endometriosis are, yeah, I'm quite glad that you that I know you. So, so last and not least is Mr. Konstantinidis. He's a thoracic surgeon. He is operating by virtual robotically. He's very experienced and skilled. So, Kostas, thoracic endometriosis symptom is a rare condition, but not as rare as people think. So Wendy is dealing with that. Also, her knowledge is also very vast regarding this issue. So, Kostas, did you want to share some thoughts on this topic with us?
Yes, of course. I would like to thank you, Dinos, for this webinar, to organize this webinar. I believe that this type of webinars regarding endometriosis is not only helpful for patients, but for us as well as the doctors, as the surgeons, because we all need to evolve and to know regarding endometriosis in all aspects of this disease, which is benign disease, but it's not benign for the patients. So I will always remember one patient about 5 years ago, before I met you, that she presented with a second episode of a recurrent pneumothorax on the right side. So I operated on her. I did a pleurodesis, and everything went well, but she came back 1 month later with a pneumothorax again. So at that point, we discussed with a lady, and through the discussions, we determined that this was during the cycle. So I went back to my video, because we always record our videos. And when I saw the diaphragm, I saw some, some holes in the diaphragm. So I looked, but I didn't see at that point. So we went back to the operation, and we repaired the diaphragm with a mesh, and we did the pleurectomy. So this is the most common type. I say that this is the most common type that we as thoracic surgeons, we should get involved to treat a catamenial pneumothorax. I always prefer to do a thorough inspection of the pleural cavity, the diaphragmatic surface, and the pleural surface as well, and excise the nodules on the diaphragm, either to repair with normal stitches, or to put a mesh if there is an extensive destruction of the diaphragm. And the pleural, regarding the type of pleurodesis, because we have to treat not only the endometriosis, but the symptoms that the patients suffer, which is the shortness of breath or chest pain that were caused from the pneumothorax. I prefer to do a pleurectomy because this will give a tissue diagnosis as well, a complete removal of the pleural nodules, which may not be present visually. We may not be able to see them, but I prefer that instead of doing a simple talc pleurodesis. So this is the preferable technique for repairing and operating a lady with a catamenial pneumothorax. In case of lung endometriosis, which is much more less common to see a lady to have a catamenial every month hemoptysis. It depends on the site. If there is a nodule on the lung surface, we may do a wedge resection, a simple wedge resection. I've never done a lobectomy, but I can see that there is reported in the literature, but I think it's too aggressive. But if it is needed, of course, we may have to do that. So we've done a couple of wedge resections for the last year. And in case of an airway nodule, which is much more less common, then we may need to ablate it endoscopically. So, but this is the common type of I would say the easiest type to recognize and to diagnose a patient with endometriosis. Most of the times, patients have symptoms for many years. They have pain in the chest, atypical pain on the shoulder, or even in the neck. So usually the patients come after 2, 3, or 4 years after they visit many doctors to see their cardiologist or a respiratory physician, and finally they are diagnosed with possible potential endometriosis. So regarding this type of symptoms, it could be related to the diaphragmatic endo, which may be under from the peritoneal side of the diaphragm, or from the upper side, from the thoracic part of the diaphragm. So at this point, usually we do an MRI scan to recognize some nodules on the diaphragm or on the pleura, but it's not 100% sensitive. I think that the most important is to take a thorough medical history, physical exam, and to have the suspicion, a strong suspicion for diaphragmatic or pleural endometriosis. So when we treat the patient with a diaphragmatic endometriosis, we may do a combined procedure, as we have done with Dinos many times, to do a laparoscopy first to see the surface, the undersurface of the diaphragm. Most commonly is the right diaphragm, and then do a VATS procedure, a robotic procedure, to see from above as well. So lastly, I would say that hemothorax is quite rare. I once have seen a patient with a pleural effusion with a hemothorax because of a pleural endo, and the symptoms are quite acute at this point. So to conclude, I would say these are the most common types of thoracic endometriosis, and usually the VATS approach to do diaphragmatic repair or pleural apposition technique is helpful and therapeutic for the patients. I hope that I spoke as a thoracic surgeon.
Yes. So thank you, Kostas. Some questions from the patients. So the first is for you. Can deep chest pain on coughing be a thoracic symptom?
Deep cuff pain?
Deep chest pain, sorry, or on coughing? On
coughing. It could be related, but it's not the most common symptom. Usually the pain is quite tight. It's not related to movement or cough. It's not purely musculoskeletal pain. So it's not very common to see this type of symptom related to endometriosis.
Okay, thank you. So Nikos, Mr. Brat's question for you. Is it possible for endometriosis on or in the bladder to be misidentified as ureterocele?
It's quite difficult because endometriosis normally affects the posterior wall of the bladder or the dome of the bladder. It's almost impossible to affect the anterior wall of the bladder. Because of the pouch between the bladder and the uterus doesn't go all the way down to the trigone, it's very, very difficult to have a lump infiltrating the bladder wall very close to the ureteric orifice. So the identification of the uterocele is quite restrictive. So I think it's very difficult to misdiagnose uterocele with endometriosis.
Thank you, Nikos. So Kostas, a question for you. Can MRI scans show spots on the diaphragm that mimic endometriosis? Does diaphragmatic endo always show with marked borders on imaging?
I didn't hear the second part, Dinos.
So does diaphragmatic endo always show with marked borders on imaging?
So sometimes we may see some benign pleural plaques on the diaphragm or in the pleural. These plaques are most common at the pleural surface, but with a specialized MRI scan and an expert on the MRI scan, we can differentiate between endo and purely benign pleural plaques. So when we find the suspicious nodules, it's clear that that they are endometriosis.
Thank you. So Mikey, do you want to get a question? So a lady asks, when she gets really back pain, she has a hard time to control her legs. Can that be endo on the nerves?
Yes, I mean, listen, I think there's always a possibility of having endometriosis on the pelvic nerve. So you can have endometriosis around the nerves, you can have it on the nerves, you can have sort of sciatica with endometriosis on the sacral nerve roots as well as the lumbosacral trunk sciatic nerve. But also the inflammation from around the nerves can cause cyclical pain, okay? So it's important to distinguish actually endometriosis. It is actually quite rare to have isolated endometriosis of the sacral nerve root or lumbosacral trunk. We've seen them, we've operated on patients like that, but honestly, it's not as common as deep parametrial disease that is compressing or being into cross relationship to the sacral nerve roots, where the inflammation irritates the nerves. Therefore, it goes into the sciatic nerve because it feeds to it, and you have the symptoms of sciatica. I think maybe one thing to mention also, there was a question earlier on about modalities for diagnosing. I think Abushik was answering it. Endometriosis of nerve endometriosis. So what do we use? So I agree with him that we use MRI mostly for diagnosing or looking where the disease is. We use also MRI neurography every now and then for patients where we don't actually see an obvious endometriosis, but where we want to be absolutely certain that there's no disease on them. And it actually works really, really well. But yet again, it's such an expensive test that not everyone can have it. And everyone.
Thank you, Mark. Yeah. Thank you for your input. So another question now, we're answering the questions that people have sent. Ben, a lady here asking that she had surgery in 2013. She was diagnosed with endometriosis, and she has recently undergone a new an MRI because she has severe gastrointestinal symptoms, but the MRI was not done under endometriosis protocol. She also is suspecting of diaphragmatic endometriosis. Should she have another MRI under endometriosis protocol?
Can you repeat, sorry, how many years ago did she have the surgery?
2013, she had endometriosis diagnosed in a lap surgery. She still has severe gastrointestinal symptoms. She had the MRI that was not done under endometriosis. So the question is, how important is to do the MRI under endometriosis protocol?
Yeah, I think it's a very good question because all of these things are like it really depends who does them, who reads this investigation, and it's similar to us as surgeons as well. Is the surgery is only as good as the surgeon is. It's the same as the MRI or ultrasound as well. Like it's only as good as the person reporting it. And endometriosis is not easy to diagnose on MRI for people that are not used to report it. So it can be quite easily missed from radiologists that are not usually do this kind of like diagnosis fairly routinely. You need to have a specific type of radiologist that is used to look for endometriosis. And I think with an ultrasound is even more clear. This you can have sonographers that can miss large bowel nodules, and you have other sonographers that are incredible. That can find nodules near ureters. Yeah, sorry, Mikey.
I think Ben, I think you're spot on it. And to answer the question even more, Dinos, I think yes, you need to have an MRI protocol
Yeah.
for endometriosis. Okay, if you're gonna have an MRI for let's say for urological causes, we're looking at ureters or other soft tissues. There's a difference between the how the MRIs are essentially done. And the view is not going to be the same as MRI specifically with endometriosis protocols.
Thank you, Ben. Thank you, Mikey. So another question to Ben. Is it hard to keep the fertility during surgery?
It really depends, like how extensive is the endometriosis. Once again, like because with the question,
This lady is worried. She's going to have a surgery. She's worried whether her fertility will be harmed during surgery.
So it is really it's a difficult question with once again, because we do know that if, for example, like you have an endometrioma, so a cyst caused by endometriosis at the level of the ovary, as by treating the endometrioma in different ways, which could be like, for example, like stripping it or like using alcohol sclerotherapy, this can affect the ovarian reserve. It's going to cause a reduction of ovarian reserve. But at the same time, we do know now that treatment of endometriosis with excision does improve the chances of fertility, like for spontaneous conception and for IVF. So if on one side, yes, you can cause an impact on the ovarian reserve, usually treatment of endometriosis does improve the chances actually of conception.
Thank you, Ben. So Nikos, Mr. Gradis, another question for you. Is there a correlation between UTIs and bladder pressure and urgency after UTI has been treated and cleared to endometriosis?
It could be. It definitely has to be excluded. It's a vice versa relationship. Recurrent UTIs can be misdiagnosed with endometriosis, and endometriosis can be misdiagnosed with recurrent UTIs. Normally, a urine culture is giving the answer, but there are women that they have continuous symptoms of the lower urinary tract, mimicking urinary tract infections like cystitis. And yet we cannot find any bacterial cause. So this should arise the possibility of endometriotic tissue somewhere pushing the bladder wall, and we should investigate first of all, with the urine culture, then ultrasound scan, and definitely flexible cystoscopy to look into the bladder mucosa, how it looks. Definitely it can be misdiagnosed.
Okay, thank you, Nikos. So, Mr. Georgopoulos, a question for you. There's a lady here asking that she has a lesion next to the bowel. She doesn't know if it is going into the muscle of the bowel. What symptoms would that cause if she has endometriosis in the rectum?
Okay, the most common symptoms are dyschezia, bloating, and sometimes they feel very, very the feeling like full distension for all the bowel, because if it is big nodule in the lower part of bowel, it could be press all the lumen and giving symptoms like that I told before.
Thank you, Mr. Geropoulos. Kostas, another question for you. Can shoulder pain be referred from this lady asks if shoulder pain can be a reflection from the pain inside the pelvis, or is it due to thoracic endo?
It could be probably related to a diaphragmatic endo, and maybe she has an endo, a diaphragmatic endo, and she's not diagnosed. Purely pelvic endometriosis, it's quite rare to cause shoulder pain.
Okay, and another question for you. I think many you have the most questions. Can lung symptoms mimic pleurisy?
Pleurisy. Yeah, I think lung. So the question is if lung symptoms.
Lung symptoms from endometriosis.
From endometriosis.
Yes.
Purely lung endometriosis, no, they do not cause pain, pleuritic chest pain, if there is nodules in the lung surface or in the pleural on the lung, but pleuritic type of pain can be caused by pleural endometriosis.
Okay, thank you, Kostas. So, Nikos, another question for you, Mr. Bratis. Another viewer here asks, she's currently 8 weeks post-op. Her main symptoms, cyclical pain after passing urine. There was no endometriosis found on the bladder. She also has lichen sclerosus and a narrowing of her urethra. What it could be the cause of cyclical pain after passing urine if all endo has been removed?
Cycle pain normally refers to endometriosis. It's quite common. If she had a thorough investigation during the operation and there was no involvement of the bladder, we need to find out whether there was a deeper endometriosis that could affect the nerves. The other thing is it's very it's quite rare for the stenosis of the urethra not to cause any lower urinary tract symptoms, but the cyclical pain is what makes me a bit confused. I think it should be investigated again more thoroughly whether there is any involvement of the bladder itself for that.
Okay, thank you, Nikos. Mikey, so you're dealing with neoperibiosis cases. So another question for you: can sharp nerve type pains of endometriosis be classified as neuropathic pains?
Say that again, Dinos.
Can the sharp nerve type pains of endometriosis be classified as neuropathic pains?
It's a very good question. I personally think that they can. Okay, from my experience in speaking to people that like yourself were speaking to Mark Possover, to the prof, and everyone else that deals with neuropalviology patients. Not those patients don't come. They don't all have the same symptoms. Those symptoms vary dramatically from one patient to another. Some patients will have even when it comes to, and that's what's fascinating about endometriosis actually, that even when the disease is found to be in exactly the same anatomical position, the symptoms might still differ. Some of them might have functional pain, functional symptoms like foot drop, where they can't walk properly. Some of them might just have sciatica themselves. Some of them might have cyclical pain that just comes around in cycles without actually, even though when the nerve is being compressed. So I think the one thing that we are clear on is that we still don't understand how the disease itself progresses so much. And from the patients that we've operated on, really sort of big majority of the sciatic endometriosis cases were isolated lesions with very minimal endometriosis in the pelvis actually, but most of it was in the parametrium. So it's just a fascinating disease that we still really need to learn much more about.
Thank you, Mikey. Mr. Gratis, possible kidney and/or ureter endometriosis as low pain and severe bladder symptoms. If present, which changes would be seen on an MRI scan?
So that gives us the suspicion that there is a nodule, either pushing extrinsic nodule that pushes the ureter very close to the insertion of ureter to the bladder, or a surrounding tissue that infiltrates the ureter itself. So both low in pain with lower urinary tract symptoms, an MRI with endometriotic protocol should show the nodule, but at the same time, we should do an ultrasound scan of the kidney, and that would probably trigger another scan. We can use the CT urogram or the MRI urogram to find out exactly how obstructive the kidney is. But definitely it needs to be investigated and estimate the risk of silent kidney loss. So MRI to start.
I completely agree. Yes. Okay. Thank you, Nikos. Kostas, another question for you. So in the pelvis, the symptoms are not proportionally related to the amount of the disease we find. So a viewer here asks if thoracic endo, like other endo, could one lesion cause a huge amount of pain? Does the surgeon often find patients with no pain and loss of disease in the thoracic cavity?
But yes, it could be done. Actually, the time for the operation is the most important. When we operate in patients that are beyond far her cycle, it's most likely not to see many nodules on the surface. So the most important is to operate into these women as it gets on the first couple or 3 days after her cycle begins. So this is the time that we will most likely see all the nodules, or the diaphragm or the pleural as well, and to resect them. So I believe that it's the time crucial to find as many nodules as we can, and to correlate the type, the symptoms of the patients to the endo extent.
Yeah, thank you, Kostas. So we are closely coming to the end. So I will ask the same question that the viewer here asks. I will ask it first to Kathleen, the same to Wendy, and the same to Vicky. So Kathleen, a viewer here asks, if you have one wish for the development of treatment in endo in the next 10 years, what would your wish be in a few words?
I think my wish would be that we would recognize it as multifactorial and multidisciplinary disease, that it affects every part of the body from the mental health right down to the very physical. I think just recognizing that impact. We're not going to have a cure in the next 10 years, but we can develop really good management tools. But that all again stems down to, and I'm going to say it again, listening to patients. So that's my wish.
Yeah, very important. Thank you for that. Wendy, what would your wish be?
one sentence that you walk into your general practitioner, that they're competent in asking the right questions and referring you to centers of excellence that have multidisciplinary teams, and they have augmentive teams as well after surgery, that they can address every need that you have.
Thank you, Wendy. And Vicky, what would your wish be?
My wish, taking in consideration some medical conditions of my friends also. First thing is that when you work to a gynecologist, giving medication as the easy way out of treating your patients, it's not actually the solution. Actually listen and make sure you have endo on the back of your head. Like it's should be one of the first things that should try to reach out and see if it's affecting the body or not. Instead of phase 2, instead of saying, oh no, it's just your period, you're just in pain, take your pills and go home. So treat the person, not avoid the person. It's two different things.
Okay, so we're coming to the end. So to conclude, the most important is for people, for medical professionals to listen to the patients. As Kathleen said, this is the most important. Listen to the patient. On the other hand, patients are obliged to keep pushing for answers, for treatments. Not give up. This is not the way to deal with things. We don't give up. We push for answers and solutions. So I would like to thank all of you for being here, especially our panel. I especially thank Kathleen. I know she's very busy, and Wendy too. They're very busy, and they sacrificed 2 of their hours on Sunday afternoon for us. So I'm very honored to have you here. And I also thank my colleagues, Vicky, and all of you for being here today. I'm sure we will meet again. So stay safe and keep pushing the boundaries. This is what we have to do. Thank you very much, all of you.
Thank you. Bye.
Bye, everyone. Have a good evening.
Bye.
You too. Bye. Bye. Bye.